Dr. Rajeev Muni for this multimodal imaging in RD. Rajeev, you can start
yes,
sharing.
Yes. Can you see my slides now?
We saw, but now not.
Oh, okay. 1 second.
A couple of minutes back we saw, but I think.
Okay.
Yeah. Okay, perfect.
Okay, well, thank
Everything
you,
good,
Dr.
Start, yeah.
Yes, thank you. Thank you, Dr. Varma and the organizing committee for inviting the ASRS and for me to give a talk today on multimodal imaging and retinal detachment repair. I have no relevant financial disclosures. This is a patient with a superior macula off rhegmatogenous retinal detachment, and this is a common presentation in all of our retina practices. And there's a number of ways that we can treat these patients. We can do scleral buccal, we can do pars plana vitrectomy, or we can do pneumatic retinopexy. And we know that regardless of the technique that we use, generally we're able to achieve a retinal reattachment relatively successfully, and the patient can do well and have great visual acuity. And this is a patient 3 months following pars plana vitrectomy for a MAC-off RD, and you see the vision is 20/25. But in this patient's mind, their surgery wasn't as successful as we're telling them it is, because when we looked at the vertical and horizontal metamorphopsia score, there was moderate metamorphopsia and anisoconia, which goes from 1 to 30, and this patient had an anisoconia score of 24, which is very severe. So they saw everything as smaller in one eye and normal size in the other, which can be very debilitating for patients. You know, we have very limited high quality randomized controlled data on various retinal detachment repair techniques. There's maybe 1 or 2 studies comparing each potential option. And our group did this study several years ago looking at the outcomes of pneumatic retinopexy versus vitrectomy for primary retinal detachment repair that met certain specific criteria. And the visual acuity was better in the pneumatic group at every time point, including the 1-year endpoint. It was different by about 10 letters at 3 and 6 months, and different by about 5 letters, favoring pneumatic at 12 months, with most of the cataracts removed in the vitrectomy group. But what was most interesting about the pivot trial results to me was that vertical metamorphopsia, an outcome that was very poorly studied in prospective randomized data before, was significantly worse in vitrectomy versus pneumatic, not only in the severity of the M-chart score, but also in the proportion of patients who had metamorphopsia. And this is something that was very enlightening for us, because for the first time we thought, okay, you know, why is this difference occurring? And is there something about the techniques that are causing these differences, and what can we learn from that? So the first thing that we did is we went to the OCTs, which had all patients had OCTs at multiple time points, and we sent all of the OCTs to our colleagues at the Doheny Retina Image Reading Center, and in a masked fashion with 2 masked graders and a senior adjudicator that was also masked to treatment decision, we found that ellipsoid zone and external limiting membrane discontinuity was significantly worse in vitrectomy versus pneumatic retinopexy. And you can see here it was about 7% versus about 20 to 25% for each of those outcomes. And when we looked at the patients who had the discontinuity in the pneumatic group, those were the patients, more than half of those were the ones that failed pneumatic and went on to vitrectomy. So again, it was very suggestive that the process of reattachment here varied. And if you had a vitrectomy, that whether it was for a primary vitrectomy or if it was a failed pneumatic that went on to vitrectomy, that there was a greater risk of these abnormalities. So why is this happening? And you know, one of the thoughts that we hypothesized was that in vitrectomy, when you're doing a rapid reattachment, forced reattachment of the retina with the RPE, perhaps there's an abnormal interdigitation of the photoreceptors with the retinal pigment epithelium, and this may lead to this discontinuity that we're seeing, or these gaps in the outer retinal bands. And if we compare that to pneumatic retinopexy and the technique that we use, Typically, we inject this gas bubble and it occludes the retinal brake. And then, as we know, the retinal pigment epithelial pump reabsorbs the fluid naturally. And perhaps that gives us a better adhesion of the photoreceptors with the retinal pigment epithelium, or interdigitation. The second outcome that we wanted to look at was this concept of retinal displacement. And in 2010, Shiragami's group in Japan described these hyperautofluorescent lines that were present following vitrectomy surgery in approximately 40 to 50% of patients. And these data were replicated by Italians and the British as well. A number of groups have shown these rates of retinal displacement following vitrectomy. And we wondered, in pneumatic retinopexy, could there be a difference in the rate because, again, of the different techniques that we're doing? So this publication came out in 2020 from called the Integrity Study, where we looked at the rates of retinal displacement in a retrospective cohort that was multi-center that looked at the rates of retinal displacement. And we found that the rates were 7% in the pneumatic group versus 44.4% in the vitrectomy group, which was again consistent with the results. The 44.4 is consistent with the literature on the rates following vitrectomy, but the pneumatic rate was significantly lower. And again, pointing perhaps that there's a difference in the technique that could be causing these changes. And here you can see in this picture, there's these very prominent retinal vessel printings that we call, and what we refer to this as a low integrity retinal attachment. So even though the patient has achieved retinal attachment, it's not ideal because the retina is in a different position than where it was before, and that may be responsible for some of the symptoms that they're having. Here's a patient following pneumatic retinopexy, and just to contrast, in this patient who had 20/20 vision following retinal detachment repair, there's no retinal vessel printings on the fundus autofluorescence. So this paper just is in press now in ophthalmology. It's a prospective study, multi-center, again looking at the same question, and again in this subset of macula off patients that was non-randomized, the risk of retinal displacement was 14% in the pneumatic group and 50% in the vitrectomy group. And again, this confirmed the findings. But what was most important was that we found that this anisoconia, we objectively measured anisoconia, which is what we think is due to a stretch of the retina. The retinal displacement is when the retina gets stretched. And so we think there's a change in the cone mosaic. And this leads to this perception of micropsia and distortion that patients have. And we were able to objectively measure this outcome and find that there was a significant difference between the vitrectomy group and the pneumatic retinopexy group. So in summary, how do we assess the integrity of retinal reattachment? We look for these retinal vessel printings, and the mechanism is that there's a flow of subretinal fluid under the thin elastic retina, and that leads to this stretch of the retina. So again, as this the buoyant force of a large gas bubble displaces residual subretinal fluid, we think that this flow of fluid leads to this stretching of the retina, and that's what leads to patients seeing things as smaller, or this micropsia finding that we're noticing. Now, someone might question, okay, so if someone has a little retinal displacement, how much does that really impact patients, and what's the severity? And so this is a really interesting case of a patient with a supratemporal macula off retinal detachment. And here you see the fundus autofluorescence. You can see this very subtle white line above this vessel. And so, it doesn't look that bad. And you would think, okay, well, there's a little bit of displacement, this can't really be, maybe it's not that significant. But what was unique about this case was that because the patient had a detachment in their other eye, we had a fundus photo and autofluorescence of this eye before it even had a retinal detachment. And we were able to use these new techniques that we're developing called homography for retinal images, where we're able to superimpose images using certain landmarks, and we're able to look at the change. And here you can see the autofluorescence in the color photo, and look at the extent of retinal displacement. Even though we only saw it here in a couple of vessels, you can see that the entire temporal retina that was previously in one location has now shifted down. And how do we know that our alignment is accurate? Well, we look at the parts where the retina was not detached nasally, and you see that there's perfect alignment nasally of the retinal vessels and the optic nerve. And so this really highlights that what we're seeing on autofluorescence is really just the tip of the iceberg, that it's actually much more severe than what we're seeing, and probably more frequent than what we're seeing as well. What are some of the other imaging biomarkers in retinal detachment repair? We recently also looked at on-fast OCT, and we found that patients following retinal detachment repair have this area of hyporeflectivity on the on-fast OCT that gradually improves over time. And we learned a couple of things from this study. Number one, that this change in hyporeflective area correlates with ETDRS visual acuity improvement, and also that you see an improvement up to 7 years postoperatively. So we can tell patients that their vision can significantly improve. We also found, we looked at these outer retinal folds, which are these foldings of the ellipsoid zone and ELM bands. And we found that on-fast OCT can be very helpful in showing us these hyperreflective lesions. And we looked at our pivot data set and found that patients who had these outer retinal folds had 10 letters worse ETDRS visual acuity compared to those who did not. We also looked at the presence of persistent subretinal fluid blebs, which we see with various techniques. And we looked at the on-fast OCT to show how this fluid improves over time and how we can get resolution. And it always resolves by about 1 year. Finally, we looked at the staging of retinal reattachment, and we looked at how the retina actually reattaches over time. And using OCT imaging, we were able to document gradually how the retina progresses through these stages of attachment. And as you go through the stages of attachment, you have this recovery and attachment, and the integrity of the outer retinal bands gradually improves. And why is this important? Because we've realized that these outer retinal corrugations can lead to outer retinal folds, which is what we noticed was associated with worse visual acuity. And this is an example where the corrugations are gradually resolving, and you see that they're resolving prior to retinal reattachment in pneumatic retinopexy, and where we get less of these outer retinal folds. And this is a final video here showing a patient who develops a residual subretinal fluid bleb, and using both the on-fast OCT and the cross-sectional OCT, we can see that the fluid is gradually improving over time. And here you can see the fluid puddles kind of separating and resolving. So we all talk about this wallpaper analogy for retinal detachment repair, and we all do a great job in achieving retinal reattachment, but we have to start thinking a little bit deeper now and see how can we improve our outcomes even further. And it's not just about looking inside and telling the patient, you know, your retina is attached, you've done great, but using our imaging modalities to see what the integrity of that attachment is. Are there any folds? Is there stretching? Is there residual fluid? Is there discontinuity of the outer retinal bands? Thank you very much. Sorry for going a little over.